Syndrome of inappropriate antidiuresis due to reset osmostat in small cell lung cancer. Our learning objectives are to understand the clinical presentation, workup, and differential diagnosis for syndrome of inappropriate antidiuresis due to reset osmostat, and to consider a rare pathophysiologic mechanism for SIAD. A 61-year-old woman with 30-pack-year smoking history presented with nausea, vomiting, and diarrhea 1 month prior to admission, and shortness of breath, orthopnea, and leg swelling 1 week prior to admission. On exam, her blood pressure was 218/117, and S3 heart sound was present, as well as bilateral crackles and edematous extremities. Labs were notable for a serum sodium of 115, serum hypotonicity at 243, urine osm of 216, urine sodium 44, FeUA of 11%, and fractional excretion of sodium less than 1%. Morning cortisol was 17.8 and TSH was 2.27. A CT chest revealed a mediastinal mass. Pleural effusion was diagnostic for small cell lung cancer. Further imaging revealed stage 4 small cell lung cancer with superior vena cava syndrome, left frontal lesion, and liver metastases. The patient was treated with chemotherapy, carboplatin, and etoposide. In the following months, she remained mildly hyponatremic to 133, 126, 125. Several months later, the patient developed nausea and vomiting with hyponatremia to 116. She was admitted, and following improvement in serum sodium from 115 to 133, her urine osmolality increased from 143 to 771. The patient was diagnosed with SIAD with reset osmostat due to small cell lung cancer. This graph demonstrates her urine concentrating ability with serum sodium on the x-axis and urine osmolality on the y-axis. This graph demonstrates an ability to increase urine osmolality while the patient was mildly hyponatremic. The low urine osmolality was evidence of ability to dilute at very low levels of serum sodium, and yet the urine osmolality increased to very high levels while still mildly hyponatremic. Reset osmostat may not be as benign as discussed in the literature when due to malignancy. A possible mechanism for SIAD due to lung cancer is discussed.